Hi, I am Ninad here, and today I will be presenting about Virtepex, a system for virtual remote telephysical examinations. This work was done in collaboration with my co-authors Kevin Desai, Balakrishnan Prabhakaran, and Thiru Annaswamy. During an in-person strength assessment, a provider usually grades the strength of joints into discrete levels by physically interacting with the patient. However, there is an increasing need to provide accessible care to those unable to make in-person visits. Over the past 2 years, telehealth adoption has accelerated due to the pandemic. However, current standards are often found lacking. Our needs assessment study indicated that physicians were willing to adopt novel telehealth procedures and desire the ability to monitor specific joints and obtain high-level but principled feedback on range of motion and strength. So we asked ourselves, can we do better than the current standard of video call in providing principled feedback? Virtepex uses a markerless force estimation pipeline to estimate the strength of an observed upper body arm movement, like, for example, the elbow flexion. It also enables an asynchronous mode of evaluation for non-urgent, routine care. In terms of ease of use and strength estimation detail, Virtepex lies between the two extreme ends of rehab monitoring systems, with a simple video call on one end and complex haptics and sensor-based systems on the other end. Our primary motivation was to enable a easy-to-use but objective feedback mechanism for physicians in performing a remote strength assessment procedure. Here, we briefly go over the workflow for a Virtepex guided assessment. For a specific upper body joint like elbow flexion, we track joint angles using the Microsoft Kinect depth camera. It provides real-time information about the 3D position of different human body joints and also supports tracking the hand gestures of a user. Via the open or closed hand state, we infer the start and end of a user activity session, which gives us the range of motion for the specific joint along with the total time it took to perform the movement. Using these two values, we estimate the force required to perform the movement via an inverse dynamics solver. The estimated force is used as a proxy for the strength and transmitted to a virtual object like bowling ball for interactive and visual feedback to the physician. The virtual environment was developed using the Unity game engine for simulating physically plausible motion of the virtual objects. In the asynchronous mode, the physician has an option to compete with a pre-computed force estimate of a patient and evaluate how well the patient performs against their own movement. Virtepex is developed following participatory design principles. During the design phase, we evaluated the system with three experts from physical medicine and rehab department. The design process began with a needs assessment study for discussing current telehealth methods and some of the challenges faced by physicians in assessing strength remotely. This study formed the core part of the initial guidelines. Following the study, we enhanced the prototype by modeling the assessment like a virtual exercise game and providing an option for having asynchronous evaluation. We validated the implementation of force estimation pipeline with a simple experiment. A positive linear correlation was found between the estimated force values and the range of motion. The experiment involved repeated motions of the elbow flexion with varying degrees of range of motion, but keeping the time for the movement same, since the estimated force values essentially depends on two things, the range of motion and the time for the movement. Now, we take a look at some of the in-game interactions of the system. We begin with a demo of the tutorial scene, which was included to help familiarize users with VR and hand gesture-based controls. As we can see, the ball changes its color to signal to the users about the current inferred state. Next, we take a look at the pin hit scene, which is a virtual object like the bowling ball as seen in the video. Virtepex has the ability to track four upper body joint movements involving the elbow, wrist, and the shoulder. The estimated range of motion is also displayed alongside other important metrics like the hand state and specific movements being tracked. You can notice that for the shoulder joint, we track two types of movements, the shoulder abduction and the shoulder flexion, whereas we only consider the flexion movement for the wrist and the elbow. Finally, we see a video from the asynchronous mode of Virtepex, where we simulate a collision between two bowling balls corresponding to two different users. In this mode, an opponent or a secondary user has already performed the joint movement and recorded their force values with the system. Using these recorded values, the main user can compete against and test themselves, for example, against a benchmark set by the physician. Such a mode also has application in long-term rehab monitoring, where a patient can track progress against their own personal benchmarks. We evaluated the design of Virtepex by conducting experiments with 10 experts from the physical medicine and rehab department of a local Veterans Affairs hospital. The main goal of the study was to measure the effectiveness of the system as a tool for evaluating patients remotely and in an asynchronous manner. The experts interacted with the different scenes inside the virtual environment and tried to evaluate the strength of a pre-recorded user. Then, they scored Virtepex along the four themes of ease of use, quality of experience, comparison with in-person, and comparison with telehealth. In the expert evaluation, Virtepex fared favorably in comparison to the standard telehealth procedure due to its objective nature of feedback and overall ease of use. Improved ease of use is critical since that is a key factor in real-world adoption. As expected, an in-person interaction was still considered better than Virtepex, presumably due to the much stronger signal for a patient's strength by the physical isometric test. However, it is important to note that beating or replacing the in-person interaction was not the primary design goal of Virtepex. There were a few limitations with our system that were noticed during the evaluation phase. We note that Virtepex cannot obtain high-precision force estimates due to its modeling assumptions, and for such use cases, on-body sensors might be better. On a related note, the range of motion and time computation are dependent on accurate hand gesture inference, and hence, errors in inferring the hand state can lead to noise in the downstream force estimation. As a part of future work, we plan to leverage the webcams found in laptops instead of the Kinect camera. With the recent progress of deep learning models on the task of monocular human pose estimation, webcams in laptops can potentially be used for real-time motion inference and providing accurate 3D positions for the upper body joints. Lastly, I would like to acknowledge Kirtana, Richard, and Sarah for their help with the project. This concludes my presentation for our Virtepex paper. Thank you for listening.